Hi everyone, this is Nakia. I am now turning into a PGY3 internal medicine resident in the US, and one of someone I know was asking me, how to, approach PGY 1 year, and it feels like it was just yesterday when I was doing my intern year, and I was so clueless on what to do. So I just felt like making like a short video on how to approach patients. And I want to make a series, but I don't know if I'll have the time to do it. But let me just give you like a brief overview on how to see a patient in the ER when the emergency room physician calls you to see a patient. So when I started my intern year, I had no idea on how to go and see a patient on my own. And even though I had done quite a few rotations in the US, I think when you're a medical student, you only think like a medical student. So, even if you've had that experience before, where you've seen patients on your own, you're still seeing them with a medical student mindset. So it's kind of hard to transition into this physician who is going to make decisions for the patient. So usually in my hospital, the way it goes is that the ER physician calls you, and or somebody from the ER calls you, gives you the demographics of the patient, like name, MRN, which room the patient is in, and then the ER physician will give you like a short sign out on what the patient's here for. It will give you like a pretty good idea. Like the physician will say, this patient's admitted for chest pain, this patient's coming for abdominal pain, a wound, things like that. So you get like a general idea based on their sign out. The sign out may not be really accurate, so um, um, I would not rely completely on it. You still have to go see the patient and get their side of the story. The reason why I say it's not might not be completely accurate is that sometimes the physicians are seeing a lot of patients, and it's easy to get them mixed up, and they see the patient for a very short time. So it's hard to get the most accurate things, but in general, the ER physician sign out is really good, and it gives you a very good idea of what the patient's here for. Um, then what I personally like to do is like search for the patient. When I have a computer near me, I will look up the patient using the patient's MRN. And then I sometimes also look up the patient using the name to see if they have multiple or duplicated charts. Yeah, I don't always do it. I only do it when, the patient is telling me that they've been to the same hospital before and I do not see those charts using the MRN I first used, then I'll search it the patient by the patient's name or the date of birth, and I'll find different charts for the patient. So the first thing I eyeball in when I am looking at the chart is the vitals. And the vitals kind of give you a very important clue on how sick or not sick the patient is. So I like looking at the blood pressure first, because if they're hypotensive, it gets me really concerned. If they are normotensive or a little bit hypertensive, that's okay for me. But if they're hypertensive, I'm like, I really need to go down, see the patient, figure out why they're hypertensive. Are they in cardiogenic shock? Are they, in septic shock? Do they need fluids? Is it because of their heart rate? Is it because, there are a lot of things that go into your mind. Is it because they're cirrhotics and always run low on the blood pressure? So blood pressure is the first thing that I look at. And then with blood pressure, you always want to look at the heart rate. If they're tachycardic, bradycardic, um, it gives you like an idea. If their heart rate is normal, the pressure is normal, I'm not too concerned about the patient. Another important vital that you have to look at is the respiratory rate. Now, for some reason, sometimes the respiratory rate is not very accurately documented, and which is why I don't rely on the respiratory rate in the EMR as much as I rely on the SpO2. So if they're desatting, or if their SpO2 is a little bit on the lower side, or if they are using say oxygen by a nasal cannula or a venti mask or a non-rebreather or a BiPAP or a CPAP, then I'm thinking, hey, this patient's in respiratory distress. And sometimes the respiratory rate, which is documented in the chart, might not reflect that, but the SpO2 and uh, the oxygen requirement that they have is a pretty good indicator. Temperature is another one that I kind of look at to see if they had a fever or if they're hypothermic. And I live in Florida, so I don't see a lot of patients who are hypothermic. But um, in the states in the Northeast, or if you live where in a place where hypothermia is common, you probably expect to see that temperature. Um, the second thing I look at when I'm looking and doing a chart review, as we call it, before going to see the patient is the labs. And I look at the labs because if the vitals are normal and the labs are normal, I'm at more ease. Like this patient is not very, very sick. Now there are exceptions to the rules always, but just as a general rule, I feel like, after the vitals, if the patient's labs are okay, I feel more comfortable seeing them with ease. And this only applies to internal medicine. I don't know if I said that in the beginning of the video, but I don't know if it applies to peds or surgical specialties. But this video is for internal medicine residents entering PGY 1 year. So when I look at the labs, um, I glance at the CBC and the CMP real quick, and they're really good indicators of, well, if they have a white count, they might, you're kind of thinking maybe infection. If they have leukopenia, if they have thrombocytopenia, thrombocytosis, if their hemoglobin is super low, it like gives you like a good idea about like what the patient could or could not have. And then in the CMP, so let me just write this down. So you want to see at the WBC, the white count, and the platelets. And then in the CMP, obviously you look at the electrolytes, you look at like what their sodium levels are, what their potassium levels are, what their bicarb is. Bicarb is a really good um, indicator of, if the bicarb is low, you're thinking of lactic acidosis, hypoperfusion. So I like looking at, people don't give bicarb the importance that it has. And then I look at the creatinine and the BUN, which is marker of, if they have an AKI or not. AKI is acute kidney injury. So BUN and creatinine, you should also look at the baseline. So if the patient had more labs done before, or if the patient had come to the hospital a month ago and they have a baseline creatinine, it gives you a pretty much a good idea of what the patient's creatinine at baseline is. So if 1 month ago the patient's creatinine was 2, you kind of think, okay, they probably have CKD, and this is not like an acute thing that happened to them. Versus if 1 month ago their creatinine was 0.8 and today it's 1.9, then you're like, okay, they have some dehydration, some AKI, or something that's going on that's affecting their kidney function. And then you look at, the liver function test. The pattern of the liver function injury is important. Then you look at like the other labs that are there. So obviously when you eyeball all of the labs, you look at troponins and D-dimers and whatever the ER has ordered. If they have ordered an influenza panel, strep whatever, and whatever is rapidly available. So that's my approach on how I look at things. So vitals first, labs second, and then I look at imaging. I like to eyeball the imaging, and the thing I've noticed is that people look at the reports more than they look at the images. And I feel like if you just read the report, it's not going to do justice to you, because you have to look at the images to really assess the severity of the condition. So the report might say bilateral infiltrates, but bilateral infiltrates could be like really small infiltrates versus whiteout of the complete lungs. And the report may underestimate or overestimate what the severity of the patient is. So always look at the imaging. And you don't have to sit there and look at it for 5 minutes or anything like that. Just glance at it. Like if it's a chest x-ray, just open it, look at it. If it's a CT abdomen, look at it. and just scroll through it, and then obviously you won't know how to read all of it at once. You will acquire the skill as you go on in your training. But if you have the habit of looking at the images, then it will help you a lot. And I'll go over it in more detail, but a lot of times when you could actually go to the radiology department or call the radiology service after you've obviously admitted the patient and you have some free time on your hand, to look at the images with them and see their perspective on things. And if you can't find something, you can say, hey, can you show me this thing that you've read, or can you explain this? And this will improve your training in radiology as well, which is an important tool that an internist has. Um, and some programs don't have point of care ultrasound training, and if you're looking at images, if you're looking at ultrasounds, chest X-rays, it gives you like some training on even echocardiogram images, just some training on how to just glance at them, look at them, and tell if it's abnormal or normal. And that's probably all you need to know, because you have other consultants to help you out on things. And then lastly, I look at the notes. So I look at the ER notes, and what the rapid assessment for the ER was. So the rapid initial assessment tells you like what the patient came in, the vitals, when they presented, things like that. And the ER physician's note, which will tell you, the patient presented with this, this, and this is what the ER did, and now the patient's stable for admission. Um, what else? Sometimes I also look at previous HPI notes, because they're really good. It gives you like a good past medical history, past surgical history, meds, what was the patient admitted for. Discharge summaries are sometimes good. Um, and so those are the notes I look at. Try not to, fixate on things, in the sense that, if you read that the patient has BPH, okay, oh my God, patient has BPH. So like the small things are some things that you don't want to focus on, but bringing the clinical picture together. So if a patient came in with DKA, you want to know what precipitated the DKA. Was it non-compliance? Was it an infection? Was it a STEMI or an NSTEMI? So you kind of look for those things. And in those cases, like, small past medical histories may not matter as much when you go see the patient and initially talk to the patient. Obviously, they matter in the sense when you admit them and you start them on medications, that is things that you need to know, all of the medical history and all of the meds. But if a patient came in with a COPD exacerbation and are short of breath, then past medical history of nephrolithiasis is not really relevant to the patient's clinical presentation. And that's what I mean by, and you will develop these skills as you go on in your training, but it's nice to know what things you want to focus on and what things maybe you can investigate further, or talk about them later. But you want to do a rapid initial assessment and get the core data first, and then go into more of a detailed HPI for the patient. So that's pretty much it for today. This is a very short introduction on how to approach and see a patient in the ER. Obviously, when you go to the patient, the first thing when you go and see the patients is look at the vitals. So look at the monitor. If the usual patients are on telemetry, which gives you like a heart rate and somewhat of a rhythm strip also. And then look at the blood pressure, look at how the patient looks. If they're like breathing very rapidly, that's concerning. They might need intubation. If their mental status is an important indicator. If they're talking to you and with it, that's really good. But if they're really somnolent, drowsy, confused, those are concerning things. Especially if their baseline was that they weren't confused before. When you go see the patient, the first question I like to ask the patients is like, what brought you to the hospital here today, or what condition made them come here? Because they might have a lot of medical history before, but then what matters is why they came to the hospital today. Um, so you want to ask about that first. Um, I mean, I can go over like, you know, approach to different patients and different complaints like chest pain, abdominal pain, things like that. But I feel like some things are really important to know July 1st. And one of them is getting a thorough history, which is getting the HPI. And we've learned that as medical students, you know, if it's chest pain, it's radiating, alleviating, or aggravating factors, severity of the chest pain, the quality of the chest pain, or abdominal pain. So those are the things we know. But I think what really differentiates like a good internist from someone who's just doing their work or doesn't know what they're doing is the attention to detail. So you want to try to ascertain what the pain is from. And then sometimes you won't get your answers when you are talking to the patient, and that's okay. But try to exclude certain conditions by asking focused questions after you've asked like a broad question. Um, the second thing that I like to ask patients after I've taken like a HPI is their meds. Ideally, if you go, you know, if you were to go order-wise, it would be HPI, medical history, surgical history, allergies, and then meds. But I like to ask them about the meds first because it gives me like an idea about their medical history. So if they say they're on insulin, I already know that they're diabetic, you know, or if they say if they're, so I try to like at least glance at their medication list, and then, you know, if they're on Lasix, spironolactone, beta blockers, then I'm thinking, maybe this patient has heart failure. And some patients will tell you about their medical history in details. Others might not know. In that case, you can, you know, ask them more focused questions on, hey, have you been ever told that your pumping function of the heart isn't normal, or if they said that it's less than 50% or something like that, and they'll be like, yeah, I've been told that. And then you start to think, okay, I know that this patient has heart failure. And so I like to get the meds, you know, it's going to be important, especially when you admit the patient, to have accurate meds when you admit them and not miss out on things that they take at home. And then the medical history is important, the surgical history is important, allergies is important. And then, you know, obviously you want to ask about their social history, smoking, alcohol, drug use, sexual history. And then in physical examination, I think your um, you know, doing a thorough physical examination is extremely important. So if a patient comes in with a stroke and you don't do your whole neuro exam, that's really bad. You have to do like an accurate neuro exam, and not only do an accurate neurological exam, but also document it, because if this neuro exam changes over the course of you know, your day or in the night shift, then your physical examination, if it's properly documented, will give a good idea to the physician who's covering at night on whether the exam has changed or not changed. And so, you know, obviously do a very thorough physical examination. Um, Abdominal examination is also, you know, you have to be more thorough in palpation, percussion, you know, auscultate. If there's a wound, there's cellulitis, if it's wrapped in a dressing, when you go see them, unwrap the dressing and look at the wound, look at, you know, look for sacral ulcers, look for decubitus ulcers, look in, you know, the patient's throat sometimes if they have a sore throat or anything like that. And, you know, and come up with an assessment and plan. And um, good luck. I think this is enough for this video. And I'll go over more things in details if I have time. Remember to ask for help when you need it. Um, if you don't know what's going on, if you're unsure, if you're afraid of, you don't know what to do, ask for help. There's always help around. There's always your seniors, your attendings, other physicians that can help you if you need it. But you have to be thorough in getting your information first and then asking for help. And I think that's pretty much it for today. Thank you so much. Bye.